Here are some clear-cut facts about phaco incisions. Let's start with wound construction of the main incision. The following points need to be taken into consideration while creating the main 2.8 incision. First is the position of the incision. So if you were doing a toric IOL and say you needed to place your incision at 65 degrees, it's important you understand that the keratome actually bisects that 65 degrees so that your incision is equally placed on both sides. However, if you were a surgeon sitting either superiorly and temporally and not incising at a particular point, the point of incision would largely be dictated by what seems to be the comfortable positioning of the hand while the surgeon makes the incision. Point number 2, when you say clear corneal, what you mean is you need to start your incision anterior to the brown palisades of Vogt to be purely clear corneal. And finally, you need to be radial, which means you need to be perpendicular to the tangent at the point of entry to be perfectly radial. Now, how do you get to the perfect depth? The way in which you achieve that is while maintaining this correct position, that is anterior to the palisades of Vogt, absolutely radial and the clock higher that you desire, the surgeon actually holds the blade parallel to the iris and presses downwards towards the floor. While maintaining this position, then enters into the cornea, then turns slightly upwards and traverses the cornea up to a desired extent of about 1.75 or 2 millimeters, and then makes it parallel again, pierces the desmes, goes all the way in parallel and comes out without any slicing movements to give you the perfect 2.8 keratome entry. And this is what it should look like. And here's a summary of the same. Counter pressure with a cotton bud, choose the correct position, dip down, engage, enter, elevate, traverse the cornea to the desired extent, make it parallel again, go all the way in and all the way out. And here's what it looks like on stereocoaxial illumination, a well-constructed 2.8 tunnel. As I mentioned earlier, if you were planning a toric IOL, I think precision is very important. Now, in this particular case, please note how the surgeon actually bisects that position of 65 with the incision. Let's move to the wound construction of the sideport incision. With the lance tip, first decide your position, stay clear corneal, the direction is towards the center of the anterior chamber, and in a controlled manner, enter in only as much as is desired to give you the incision of your choice. This is the second incision being made, once more clear corneal, just large enough to allow for your second instrument during the phacoemulsification procedure. As you can see here, it's just large enough to allow for the second instrument. And please note that the angle between the main incision and the second sideport incision needs to be approximately 90 degrees for optimal instrumentation. One could also use a 20 gauge MVR blade to give you a perfectly created sideport incision, which would never be larger than the maximum width of the MVR. So the surgeon can choose to make just a partial entry with the MVR blade, giving you perfect control on the width of the MVR. And here, when you're moving to the point of irrigation aspiration, you can always enlarge the incision a little bit to give you ease of entry of the irrigation aspiration. And you're left with perfectly sized incisions, neither too narrow, neither too wide. Now let's understand some challenges with phaco incisions. If there seems to be any resistance while making the main incision, look at the keratome. Very often you're dealing with a keratome which has a blunt tip. So visualize your keratome under high magnification, and if you do find something like this, a keratome that is bent, it is going to give you resistance. So now you change the keratome, go back into the partially made tunnel and proceed to complete the incision as demonstrated here. Next, you can see a sideport entry made with a lance tip, which is again blunt. It's completely uncontrolled with the propensity of intraocular damage, both to the iris and the anterior capsule. In this next case, a failure to press posteriorly towards the iris while creating the main incision and thereby not getting the adequate depth results in what is a very superficial incision. And as you can see, the tendency of this superficial flap to actually turn inwards on subsequent instrumentation. Now, even though this may not have any deleterious effects to the end result with respect to astigmatism, you may not want your main incisions to look like this. So make sure that you're deep enough at your point of entry before you turn upwards to make the main incision. Failure to traverse adequately into the length of the cornea results in, as you can see, an extremely short incision. These incisions can cause significant flattening, which is undesirable. In the following case, please note that the initial part of the incision seems fine, but at the point where the surgeon needs to dip down and pierce into the endothelium, he drags a little bit more into the cornea and then presses downwards, resulting in a longer incision, which is almost like a square incision with a triangular apex, which results from a downward push of the keratome. And as you can see that in this particular case, when you then go in with your phaco probe and turn downwards into the eye, it causes a significant amount of ore locking and visual disturbances intraoperatively as a result of all the corneal striae that occur as a result of this extremely long incision. In this next case, please note the starting point of the incision. It is not in clear cornea. This is what you would call a limbal incision, which sometimes, as you can see here, at the end of creating the incision, you can actually have a little bit of oozing of blood just because of the slightly posterior position of the incision. And opposing to this is an incision whose starting point is way into the cornea, resulting in a really anteriorly placed incision. In this next case, please note a significant conjunctivalization of the cornea, due to which the surgeon is misguided as to where the clear cornea actually starts. So the surgeon actually ends up making an incision which is rather anteriorly placed, and we know that these anteriorly placed incisions now can cause a significant amount of ore locking intraoperatively during the phacoemulsification procedure. In this next case, as a result of excessive phaco power delivered into the eye to emulsify this rather hard cataract, you can see the occurrence of a wound burn. Typically, you can see the grayish appearance of the undersurface of the incision along with fish mouthing of the wound, which results with severe wound burns. Stromal hydration, on the other hand, is just a hydration of the area near the main incision as a result of backflow of fluid from the phaco tip. Even though this stromal hydration completely clears postoperatively, it can cause visual obscuration during surgery. Faulty instrumentation in a very tightly filled eye can result in a lacerated incision, as demonstrated. The problem with that is you can manage to do the case, but there is always a possibility of the tear proceeding towards the center of the eye as the case proceeds. This is a case of an epithelial detachment. This epithelial detachment clinically appears as a bubble that starts to form, goes down again, comes back again intraoperatively, and is a result of a faulty passage of fluid into the subepithelial space.